Hello there again. My name is Nadira Hamid, one of the interventional echocardiographers from Minneapolis Heart Institute. And today is such a pleasure to have one of my dear friends and colleague, Dr. Rahul Sharma from Stanford, who will be talking with us and with me in particular over the last 2 days. What an exciting TCT 2025, hasn't it been, Rahul?
It has actually. And, I think obviously we learn a lot from all of the meetings, but this year has been, I think, as you said, particularly exciting. There's been so much great science presented, so much highly anticipated clinical data. And I think that's reflected in the attendance of all of these sessions. And, hopefully we get to talk about some of the highlights.
Absolutely. Let's say day one yesterday from the late-breaking trials on the tricuspid side of things. And, we have both the Evoke and TRILUMINATE presenters. What are your thoughts about that?
Yeah, I think, the tricuspid space, there was obviously a lot of interest. The approval of both edge-to-edge and replacement devices by the FDA with commercialization of both TEER and TTVR was based on the TRILUMINATE and the TriCend pivotal studies. I think post-commercialization, there's been, I guess, a lot of questions of how will this pan out in the real world. And so yesterday we got to witness back-to-back presentation of both the late breakers, the TriCend real-world 30-day follow-up, and TRILUMINATE, Dr. Schwartz presented the entire cohort, the extended continued access as well. And I think that from my perspective, both presentations really highlighted two things: that what we saw in the trials in terms of a great signal of safety and early efficacy was maintained, so it was reassuring. And we see, even at 30-day and extended follow-up, very low rates of adverse complications in both groups. I think the delta was much greater in the TriCend study, in that the difference between what we saw in TriCend 2 and what we saw in the real-world outcomes, particularly the reduction in bleeding rates and need for new pacemakers, which I think were two of the perhaps apprehensions after the Evoke valve was approved. And I think it was very reassuring to see the rates of significant bleeding and new pacemakers come down significantly.
That's fantastic, to see that data and reassurance in the community as well. And why do you think so? Do you think that we are selecting patients better, or, what are your thoughts about it?
Yeah, I think, look, TRILUMINATE showed us that edge-to-edge repair is very safe, even in sick patients. And I think that was reflected in yesterday in Jonathan's presentation as well with the continued access. I think with TriCend, there's a few things that I think are attributable to the improvement in bleeding. Let's start with that. So in the study, there was a lot of bridging of heparin pre and post procedure, which I think contributed to some of the bleeding.
Right.
There was also the mandated use of an antiplatelet in addition to an anticoagulant after the procedure. And we saw a much lower rate of antiplatelet use in the real world data as well.
Right.
I think that, that was in spite actually of having included patients who were higher bleeding risk, such as those on dialysis in the real world data. Of course, they're excluded in the clinical trials. And I think the other reason is that, in the trials, we were using a lot more vitamin K antagonists.
Yes.
And in the real world, people are using a lot more of the novel oral anticoagulant agents, which are associated with less bleeding. So I think there's potential mechanistic explanations for why we saw a low bleeding rate. In terms of pacemaker, I think we don't know is the short answer. Perhaps there's been changes in the way we size these valves,
Yes.
Changes in the way we deploy them and how we interact with the septum and the conduction system. And I also believe that, in a clinical trial, we're perhaps a little more conservative, and, whether or not we were putting in pacemakers a little early or, with a lower threshold in the clinical trial versus just watching and waiting on these patients a little longer in the real world.
That's right. And, now we have more than a year, I guess, of the real world experience of both the repair and the replacement. Let's take back to your clinical practice. And I think that's what the audience would like to know. How do you If a patient comes to your clinic, how do you assess it? Just back to basics, and what can you advise to the audience with these data that just came out yesterday?
Yeah, I think it's really lending credibility to the fact that we have a toolbox now. We have 2 devices that are commercially approved. We have a bunch of other novel devices that are on the horizon in earlier stages of the clinical testing. And I think now we can say to our patients that we have 2 robust devices that are safe, that are effective. Obviously, we don't have extended long-term data on, but at least, now we've got a critical mass of patients with good follow-up. And, they're effective. Patients feel better, whether you measure KCCQ scores, NYHA class. Certainly the mitigation of tricuspid regurgitation is significant acutely and then maintained as well. And so when we see patients in the clinic, it's a choice based on, I think, first and foremost, the patient's anatomy. I think that's sort of the first step to divide as to whether the patient fits nicely into one bucket, may be eligible for both, or unfortunately, in some cases, ineligible for both. And then thereafter, it's, taking the anatomy in the context of their comorbidities, their RV function, any degree of pulmonary hypertension, the presence of leads, for example. We know, and you better than most, the importance of imaging and the adequacy of imaging.
That's right.
Particularly on the edge-to-edge side of things, I think, in terms of delivering a good result. So, what is the safest option that's most appropriate for an individual patient in the context of their anatomy? It's going to result in the least TR that's sustained.
Correct. I mean, you said it beautifully. Patient anatomy plus the imaging adequacy. I mean, could not stress enough. As an imager, the key to the success of the patient, the procedural outcomes and the durability of the procedure itself. As we know now, we are talking about how much TR reduction we should aim for each of this patient, as we want to know with the trial data in terms of durability of these results. Obviously, more to come in these 2 fronts. And now switching gears to second day, which is today, another exciting day. I mean, in terms of the aortic world, the 7-year outcome by Dr. Mack and partnered investigators, which I know you're part of it too. Congratulations. What are your thoughts? Please tell us, the audience, how now with our low-risk patients.
Yeah, I think, look, the partner data has been hotly anticipated, by a lot of people. I think, TAVR really kind of kicked off this evolution of structural heart. And one of the big questions that has been there since the start is around the durability of the data and the findings of, obviously improved gradients, paravalvular leak, and how sustained are the hemodynamics in these patients. We've seen a number of trials with early data, and the conclusion of each is we need more data. We need longer follow-up.
That's right.
And so now we have it.
Yes.
7 years is an interesting number because when you look at the surgical literature, a lot of the surgical valve failures that occur relatively early, and it's usually within that 7-year time frame. So I think 7 years is an adequate time frame in which to assess, because at least when comparing to the surgical valves, those that will fail, generally do in that time frame, and then holding up TAVR against that to see how it performs. And I think that, what we saw was that actually this is very reassuring, that the immediate positive impact that we see with TAVR holds itself up against SAVR after 7 years. The valve performance, is maintained. I think it's important to contextualize in terms of, how old these patients were when they were enrolled and what age. And so there's obviously kind of an attrition of patients with their natural survival. I think it's also important to contextualize it in terms of the devices that we were using, earlier generations of devices, and not just earlier technology, but also our strategies to implant these valves.
Right.
We talk about imaging, but, the very early partner studies were done without CT, which seems crazy as we talk about it today. But 2D echo in early partner days, and CT came in much later. Sapien Original versus Sapien XT compared to what we're using today, the Sapien 3 Ultra Resilia. There are significant leaps and bounds in technology, which clearly translate to improved outcomes, whether it's perivalvular leak.
That's right.
Gradients, how sustained the gradients are, rates of leaflet thickening and thrombosis. So I think to say that, we have data that's now 7 years old with older devices with perhaps less evolved techniques of implantation, and still holding up against surgery at 7 years is incredibly reassuring as we move to this younger, lower risk patient profile and the subject of long-term lifetime management becomes the forefront.
Beautifully put, because I'm thinking, what happens tomorrow you run your clinic and a low-risk patient comes in? What are you going to say after this data that just came out?
So I think that's a great point, because one of the questions we get asked in clinic a lot is, okay, you presented all of this, and well, how long will this last? When am I going to need another procedure? And to look at the reintervention rates, and ultimately I think all of these endpoints matter. We want a safe index procedure, and we want to be able to tell patients that the valve will perform as intended with no deterioration or degeneration that would result in either developing symptoms or worse, needing a reintervention. And to be able to now present this data to them, I think is very reassuring for us, but more so for the patient.
Absolutely. Again, the most important thing is durability. And, like you mentioned, the devices, for 7 years. And now you have different reiterations. You have different in terms of the tissue as well, and to enhance the durability. And with other newer devices of TAVR, so much in the platform, with newer trials, to help in that. And so do you think the TAVR will be the first line? That's, I know I'm putting it out there.
Provocative question.
Just to kind of be controversial, but it's such a evolving platform, because TAVR has really revolutionized how we treat aortic stenosis.
Absolutely.
And we're getting better and better. And now with this data, 7 years, how do you see or envision it now with so many other new devices? And what would you like? I know I'm asking a lot.
No, I think it's very fair. And look, I think we have to be cautiously optimistic. I think that, and our surgical colleagues are very good at keeping us in check, appropriately so.
Yes.
I think that, again, this is an older patient cohort. Now we're seeing patients, in their early 70s, late 60s, and, in the United States, above 65 is the approved indication. And we don't have long-term data in the 65 to 70-year-old cohort at a critical mass to be able to say definitively, what those outcomes look like against surgery. We also don't have the data for contemporary devices, obviously. So, starting now and moving forward, we'll be, hopefully back again here in 7 years, looking at the data from contemporary valve design devices. You mentioned leaflet tissue technology. Even our understanding of anticoagulation, antiplatelet use around the procedure and post-procedure has evolved drastically. So I think what's amazing about what we do is that we constantly hold ourselves to a standard and accountability. And that's what, trials are for. That's why clinical data is important. That's why these meetings are important, so that
absolutely
we have the academic rigor to assess what we're doing. We don't get caught up in the novelty of procedures and devices, and ensure that ultimately we're putting patients first to make sure that something is safe, it's effective, and if so, is that durable over time?
That's right. And, to that point, I really applaud one of the presenters, who is David Cohen, and I'm part of the study as well, the PREVUE study, which I'm sure you're aware of as well, the first prevalence study that is so well run, with all over the country represented by 50 states, to just highlight the prevalence and burden of valvular heart disease in this country. I mean, kudos to the team. I was part of it with the echocardiography core lab. Your thoughts about it? I know tricuspid was the highest prevalent, obviously next to aortic stenosis, but it just highlights the prevalence. And what are your thoughts in the upstream approach to aortic stenosis? And that's why I love that study, despite in the presentation of all the devices. What are your thoughts about it?
Yes, I think it's, first of all, congratulations, because it's an important study to highlight what a lot of us know or suspect anecdotally, and that is that we are treating only a fraction of the patients out there who may be eligible for treatment, be it via transcatheter approach or surgery.
Right.
And, there are a number of factors that lead into that. But ultimately, a lot of us are trying to figure out what are ways that we can identify the right patients that are out there either to get them an echocardiogram, or in fact, those that have already had an echocardiogram that may not have been assessed appropriately, or they've been assessed as having severe valvular disease, but then they sort of get stuck. And there's no mechanism to get them to a center of excellence, to a structural heart team, and then put on a pathway to be treated if appropriate. So trying to figure out the reasons for and mitigate those reasons of that funnel effect, I think are important. And it starts with understanding the prevalence and then breaking it down and trying to identify what the barriers are to translating the prevalence of the disease outside our institutions to then bringing them in to treat them, if that is indeed deemed appropriate.
That's right. I mean, we can do so much more in early detection. And so these patients get better treatment and access as well to the treatments in the country. And so with better outcomes.
Absolutely. And, there was some interesting presentations this conference about the use of adjunctive technologies like AI in terms of identifying disease on echoes as an adjunct, of course, to clinical oversight, using tools that interact with the electronic medical record to identify patients of interest, and really trying to augment what we do in clinical practice. Because clearly there's a delta between how many patients are at risk and then how many patients we're treating. I think, the other way of looking at it is that where we're intervening or seeing these patients on the disease spectrum. Philippe Genero has done a lot of work with other colleagues looking at moderate aortic stenosis, and we'll see the impact of the PROGRESS study, I'm sure, in a meeting soon. But looking at how we identify patients at risk based on the underlying substrate beyond just what's happening at the aortic valve level.
Fantastic. And we've went through from tricuspid to aortic, and then prevalence, and last but not least, the two big mitral trials that was presented. I think those two are the landmark trials. I mean, the percutaneous approach for treating MAC, the summit, and secondly, the first percutaneous transcatheter mitral valve replacement with the M3 Sapien. Your thoughts on both of these two? And I mean, isn't this times exciting?
It is. It's a great time. And like I said, this is a fantastic meeting because there's so much, not just exciting, but truly impactful science being presented. So I think, mitral, we were humbled. I think we all thought with aortic being so successful so fast, mitral would be a fast follow. And it hasn't been. It's been a long time. I remember being, involved in Summit from the beginning, transapical.
Yeah.
And, now there's more devices than I can even name in the transcatheter mitral valve replacement space.
Yes.
But it's been a tough slog. Patient exclusion from the trials is a big Achilles heel.
Yes.
And so it's been tough to enroll a lot of these studies. But I really commend both groups of investigators. MAC, as you know, is really a challenge to all of us, even our surgical colleagues. The rates of adverse events are higher, regardless of the procedure. And so these patients are tough to see in the office because they have very few options. A transcatheter solution, by the time they get to, is often their only potential salvage.
Yes.
And either because of the presence or distribution of MAC or their LVOT dimensions or a host of other anatomical factors or comorbidities, they're not even eligible for a transcatheter approach. So I think to see now at least the approval of the Tendyne device for MAC gives us one potential solution in the space that we haven't had for a long time. I think, the M3 data was truly astounding.
Oh my God.
I think, a transeptal, first of all, is everyone's first choice. A transeptal procedure is so stable even in sick patients. So that was almost a must-have, I feel, in the transcatheter mitral space.
That's right.
We learned a lot from, mitral edge-to-edge repair in that regard. But I think I personally was very pleasantly surprised by how good the results were. I think obviously, like any new technology, there's been significant iterations in terms of the design of the encircling mechanism to make that easier. Imaging has improved in terms of understanding how to confirm that you have, caudal engagement. And really, it's now a much shorter, much more streamlined procedure.
That's right.
The learning curve is steep, but, they've shown that they've come a long way from the early experience. And I really think it's remarkable, the results that were presented, even the reduction in all-cause mortality.
That's right. And also what strikes me is the 35% in terms of screen failure rate.
Yeah.
That's remarkable.
I think that truly is, because we face a lot of screen fail fatigue in TMVR trials.
Yes.
Rates ranging at best from 60%, up as high as 70 or 80% in terms of screen fail rate. And again, these are the patients, like I said, who might have no other option when they come to you. And so to see a screen fail rate, now, obviously, this is probably a sort of a relatively curated group of patients. Often there's a little bit of pre-screening that goes in at sites or in studies.
Yes.
Nevertheless, I think 35% is incredibly promising for an early technology and, our first commercially approved transeptal TMVR.
Correct. And these are high risk, not suitable for M-tier. And now we have an option. And so I'm looking forward to the approval. And so it'll be available to most, I guess, absolutely, like you say, the learning curve for both the operators and imagers. So really a lot of work still coming for Edwards and the team and the whole group, the investigators, as to how we move on and let this technology be available to most of us.
I agree, and I think, like with any technology, and certainly this has some nuances. It's unlike another technology we've used or currently use, and there will be a learning curve. These are very experienced operators at experienced centers with amazing images to help them see. Now the question is, following commercialization, how do you scale this up?
That's right.
How do you treat more patients at perhaps centers that aren't as experienced or don't have amazing images like yourself? And I think that's the next question. And then, beyond that, how do you expand the patient population beyond the kinds of patients that were in the study?
So much to do, Rahul.
Lots to do still.
Lots.
We'll be back next year.
I think we will. Well, it's been such a pleasure to have you doing this interview, just to highlight the key things that we learned from the last 2 days with the late-breaking trial. So truly, thank you very much. And with that, thank you so much for having me and Dr. Rahul Sharma in this episode of the key highlights of the late-breaking trials. With that, thank you very much.